I'll let you go ahead and kick us off, and I'll just kind of jump in and we'll have a conversation.
Sure. Well, I think it's important to remember that at some point of our lives, each of us is going to be a patient, whether we want to accept that or not. And our current system, our fee-for-service healthcare system, has many people, and most of us really, thinking in this sort of reactional way.
Yeah.
Where when we think about health and the way we respond to health, it's more responding to a sickness or an injury. It's a reactive response rather than being focused on preventing the issues from happening in the first place. And so I'd like to talk about reminding everyone that, number one, remember that half of all medical care in the country is delivered in the emergency room setting, at least pre-COVID. And I remember my own experience in the emergency room. It would be about 2 years ago. In November, it'll be 2 years, where I went here in Tampa. We have standalone emergency rooms where they're not physically attached to a hospital. And I went to the emergency room with shortness of breath. I was diagnosed with pneumonia. So I had the typical workup for pneumonia. I had the chest x-ray. I had an EKG done. I was given Tylenol. I had 2 antibiotics given to me, and I had the IV bag. And the insurance was billed almost $10,000. And in the ending, the insurance ended up paying $6,800. And I took the itemized bill to one of our office managers, and I said, this treatment we offer in all of our clinics, how much would it cost to offer the same treatment? And she went through and she said, well, Dr. Syed, the Tylenol is like not even a penny. The Rocephin costs like 50, 60 cents. Same with the azithromycin, it's like 20, 30 cents. And EKG, we do that in-house. And even the chest x-rays, the x-ray, we do that in-house. We have it read with a central team. And she said, and really in our clinic, what they offered you, and the normal saline is like $1 for the IV fluid.
Yeah.
She's like, you're talking $7, $10 at most. And she said, but if you're going to be going around telling the story at residency programs when you're doing your value-based care talks, remember that the cost of a 2-view chest x-ray is about $15 anywhere in the country. So it's about $20, $25.
Right.
And it made me just think that, wow, already we're paying. When people say we can't afford healthcare, we can't afford to treat more people, we have 30 million Americans who are uninsured, we can't afford to take care of more people, we're already paying $10,000 for
paying too much
for $20, $25 pneumonias.
Yeah.
Already.
The prices are already too high in certain areas, and there's places where things can be done cheaper. And I think what I think is really important about what you just said is that we all are patients, and we're all at risk. You're a physician, and you got pneumonia, and you ended up going to an ER just like anybody else, and getting very sick and having an astronomical bill. And that's something that a lot of families are in financial ruin with right now. And not only that, but it's also one of the reasons why wages have not increased in the United States. Healthcare costs have expanded much faster than wage growth, and it's been taking away from the amount of take-home pay that a lot of American families have been able to have. So it's something that we all are at risk for. You can walk outside and fall down. You can experience pneumonia like Dr. Syed, and it's something that is inherent to all of us.
One in 5 Americans is in some stage of debt collection because of medical billing.
Right.
The number one cause of bankruptcy in the country today is medical debt.
Right.
And it's not from outpatient going to see your doctor to get a physical done. It's from hospital billing.
Yeah.
It's from going to the emergency room. And when half of all medical care is delivered in the emergency room setting, how much of that is necessary to be done in the emergency room setting, and how much of it should be billed at those rates? I don't think it's ethical.
And I don't think it's ethical either. And it harms all of us. We're all at risk, as I mentioned, for this outcome to occur. And what I think is really important is to link back why this is the case to the way that we incentivize healthcare services to be provided in this country. And the incentives come from the top. They come from insurance companies. They come from government payers. And those incentives currently across the country are fee-for-service incentives. So they incentivize volume of care to be delivered. If you're operating a clinic that is paid in fee-for-service, your goal is to maximize your reimbursement. And so when you maximize reimbursements, you perform more services, even if they may not be necessary, and you try to drive up costs because for each episode of care, each service that's provided, you end up making more money. And that is one of the major drivers of why our healthcare costs are out of control. The incentives in the system are to provide more healthcare services. Hospitals want to fill beds. They want people to come into the emergency department, and clinics to some extent do as well. So what is the solution to this? This is a big problem, and it's to some extent wrong for everybody in the United States to be subject to this type of system.
Yeah, the healthcare system shouldn't thrive during a flu pandemic or any kind of pandemic because of people getting complications from the flu. It shouldn't be a win for the hospital system that all the beds are full because we've got a really, really good flu season. It should be the opposite. We should have tried to prevent the flu from happening in the first place. We should be rewarding providers who are good at giving flu vaccinations. I mean, even right now as a country, we're still less than 50% of all American adults are vaccinated against the flu. When you can get your flu shot pretty much anywhere. I mean, anytime I go anywhere, you go to the grocery store, you go to the pharmacy, it's always get your flu shot here, get your flu shot there.
Right. And so you guys, I know at ChenMed are very focused, and you have excellent flu vaccination rates. And you focus on this a lot because you are under sort of a value-based care system. Your incentives are to actually provide better services and to prevent costly episodes of care for your patient population. And so when you do a high value service like flu vaccination, and you're trying to prevent that bad hospitalization in your patient group, and so you are incentivized then as physicians to really focus in on trying to convince and partner with your patients to actually get a flu vaccination. Is that right?
That's absolutely correct. Our number one goal is to reduce unnecessary suffering, and especially when we're talking about unnecessary suffering resulting in an unnecessary emergency room or hospitalization. Those are the main drivers. That's by far the leading driver of medical waste in the country is all this unnecessary emergency room and hospitalizations. At a distant second is all the unnecessary referrals to specialists, and even a further down third is the over-prescribing of brand name drugs when a generic medication is available. If you started with just unnecessary emergency room visits and hospitalizations, and what are the causes of that? It's I wouldn't say it's malpractice, but it's definitely inefficient care. It's definitely a system that incentivizes more being reactive rather than preventing or even just involving getting an intervention done early on in the first place.
So when you're reactive, though, it's okay to be reactive because if you keep reacting and people keep coming into the clinic and you're not doing anything to prevent that, under fee-for-service, you make more money. Whereas in a value-based arrangement, which I think is favorable, it's something that I would like to be a part of with my provider. If I can choose between a fee-for-service provider and a value-based provider who's incentivized to keep me out of the hospital, I think that's the greater good in this situation for me as a patient across the country. Would you agree with that?
I mean, if you had to pick, what is the more ethical way to pay a doctor and nurses and the whole healthcare delivery system? Keeping people healthier and out of the hospital is definitely, I mean, I wouldn't say that value-based care is like godsend to healthcare, but it is definitely the more ethical way to reimburse doctors and the healthcare system. We should prevent those emergency room visits. The system should reward those who are better at vaccinating against something like the flu, against influenza. I mean, we have doctors, we celebrate our doctors who have over 90% of their patient panels vaccinated against the flu. We're somewhere between 70 to 80% vaccination rates as an enterprise across 10 states.
Yeah, and as a patient, getting a flu vaccine is one of the best things you can do to prevent something that might be a bad outcome from the flu, getting a flu-related pneumonia or ending up in the hospital, right?
Of course, the flu. I mean, just the flu alone. I mean, by the time you start getting symptoms, you are already shedding the virus for 3-4 days already.
Right. Right. So that's something that comes out of those types of mindset shifts under a value-based care arrangement where you're trying to think about innovative ways to actually improve patient well-being, patient health, and to actually prevent some of these deteriorations that end up in the clinic. Whereas if you're even a primary care physician, just like, ChenMed, if ChenMed were fee-for-service, you may not be thinking about how to prevent those emergency department visits because you don't really have any connection to them. Whereas under your value-based full risk arrangement, you are responsible to some extent for how well you care for your patient group.
That's right. Our doctors are concerned more about the medical complexity of the patient than they are with the medical complexity of their documentation. We don't even have a billing department. When you're full risk, the doctors aren't concerned about things like billing. They're more concerned about just taking care of their patients. Right. I mean, I think if I had to say the number one cause of burnout in the country today, especially with primary care, is that doctors are spending about 15 minutes documenting each patient encounter.
Yeah, and they sit there at Epic and they type in information, and I can't tell you how many physicians end up reaching out to me at Avenue, and they say, hey, I'm getting kind of tired of being in the clinical environment. I sit at Epic and go through my basket, all day long for 12 hours, and I don't feel like I'm practicing medicine. I'm doing administrative tasks at a computer. And they want to get into health tech because they see that as a way where they can keep kind of benefiting patients, but they do it kind of out of the clinical setting because they're getting burnt out. And, I think there's a big difference between what you guys experience at ChenMed under a full risk value-based payment system and what happens, in a lot of these other settings. Is that correct?
Well, the doctors, I've been told that doctors are getting burnt out because of the American population becoming more medically complex. And I just don't agree with that at all. I mean, the average American is still only 37 years old. Doctors are not getting burnt out from a medically complex patient population. They're getting burnt out from doing all this non-doctor work, spending 15 minutes documenting each patient encounter, just being more concerned about billing than they are with treating the patients themselves. Seeing 25, 30 patients every day, having patient panels of 2,000 to 3,000. I actually met a doctor who had over 6,000 patients in his patient panel that he was seeing with 2 nurse practitioners. I mean, it's not a sustainable system. We see the outcome. You have to see the outcome of fee-for-service. The outcome of fee-for-service of this: 30 million uninsured Americans, 40 to 60 million Americans who can't afford their copays or their deductibles, and half of all medical care, sadly, being given in the emergency room setting. I mean, it's the reason why you have 200,000 primary care doctors and 800,000 specialists.
Right.
The system incentivizes to wait until there's an issue. The system incentivizes, this fee-for-service system does not incentivize an efficient delivery model.
Right.
I mean, as a doctor, I know how much healthcare we can give just by a simple phone call. I remember when COVID started, we were able to switch to a telephonic model within a week. More than 90% of our interactions telephonically within a week, because we're not concerned about the reimbursement rates, and we shouldn't be.
Right. And in terms of well-being, you've operated in a fee-for-service environment before, and now at ChenMed, you've capped your patient panels for physicians at about 500 patients. What does that do for well-being? Are your doctors happier?
I mean, you can imagine when the goal is to restore the doctor-patient relationship. When we think of the doctor-patient relationship, most people think of bills and medical debt. It's a financial relationship. But for long before it became this financial one we know today, it was a sacred relationship.
Right.
So when you're working in an environment where the doctor-patient relationship is sacred and you're trying to restore that relationship, then suddenly the focus is on setting realistic goals, working together, the doctor and the patient, to achieve outcomes to prevent disease, to prevent illness, and actually to improve quality of life.
Right. So you can spend a few extra minutes, you can spend a lot more extra time with your patients during an encounter with them than somebody who might be a physician operating in a fee-for-service system where the administration or the practice requires that physician see a whole bunch of patients and they're sort of 15 to 20-minute visits very fast.
Yeah. It's a completely different model. In the fee-for-service world, the average doctor only spends about 20 minutes of face time per patient per year. In our world, It's well over 200, like somewhere like 220 minutes per patient per year. And actually 500 is too high. We cap our doctors at 450. As an organization, we're somewhere between 350 and 400 patients per doctor. And we're not talking young people. Our average patient is 72, 74 years old with like 5 to 7 chronic medical conditions. Every single one of them are on fixed incomes. So we're dealing with all the social determinants of.
Yeah, and it seems to me that I mean, I think it's self-evident based on this conversation, but there is an ethical consideration here between fee-for-service and value-based care. And it seems to me that for physicians and for patients, one of them is superior when you're trying to think about how you want to receive care, how we want healthcare in this country to look.
I think COVID has forced the entire country to start accelerating some of these thoughts. Moving away from this transactional fee-for-service model, more towards a value-based, comprehensive, holistic model.
Right. And to some extent, it's being debated quite heavily. Healthcare is one of the top issues in this current election cycle. And I think that value-based care is sort of a payment incentive. It's a way to actually change the way that organizations operate. And so it's not necessarily a political thing. It's just a sort of a shift in incentive in the way that we actually pay for each individual service or as a group. But there's another spectrum here that we can briefly chat about, which is, there's a lot of people who are proponents of providing more government options for people to receive health insurance, to improve rates of uninsured, to just give people who work for small businesses access to affordable health care as opposed to going uninsured, and trying to prevent some of those emergency department visits where people know that they can receive care even if they don't have health insurance. What do you think about that? Where do you stand on that issue? I know we're getting a little political here, but where do you stand there?
I think it's okay. I mean, I think it's okay for doctors to get a little bit political. I think we ought to maybe get out of our lane a little bit. I think with the value-based care model, it forces us to start looking into the causes of the causes. Yeah. And so you end up talking about things like food insecurity, transportation issues, home insecurity as a physician. And when we're talking about government healthcare, I think it's important to remember that already right now, half of all healthcare spending is under government budgets. And most of us right away, we think of Medicare, Medicaid. But let's not forget, like, there's public health, there's TRICARE, there's the Veterans Administration, there's the VA. And with Medicare Advantage, what we hear more about is Medicare for all. I mean, I think that Medicare for all would be just more of this fee-for-service. Remember, 95% of healthcare in the country is fee-for-service. Right. So I wouldn't agree with that, Medicare for all. But a Medicare Advantage for all, or a value-based single payer for all, that I'd be aligned with. I mean, if a single payer system is good enough for our soldiers, then why wouldn't it be for the rest of us too?
Right. The VHA, the Veterans Health Administration, is a single payer system, if you will. It's one of the largest healthcare delivery systems in the world. But what's interesting here is that we have value-based arrangements coming up in the private system between private insurance companies and provider groups. So we agree that is ethically a very good thing. We want provider groups and hospitals to be incentivized to provide better care to patients. Now, there is another structure, right, which is single payer coming out, or a public option for single payer. And as long as those entities may employ some of the benefits that we've seen from value-based payment, then we may be in favor of that because it creates a better coverage option for a lot of people who are currently uninsured. Is that right?
That's exactly right. And all the incentives are perfectly aligned.
Right. It's all about go ahead.
I was just saying the focus should be to improve health at the end of the day.
That is the goal. The goal here is we want to be healthier. We want people to have the ability to sort of improve their health. They want support from their physicians and their providers to build models of care where health can actually be improved.
That's right.
And under fee for service, there's really not an incentive that's aligned there between patient, provider, and payer. And when you shift to sort of a value-based arrangement, you end up aligning incentives where physicians get to focus back on caring for patients and doing what they want to do and what they do best. And patients then get to benefit from it because everybody's aligned with how they want to actually operate under a financial system.
You know, I used to be one of those people that said the fee-for-service healthcare system is broken. Our healthcare system is broken. It's broken. It's broken. And actually, Dr. Dan is the one who told me, no, it's not broken. The fee-for-service system is doing exactly what it was designed to do,
right?
Which is to generate revenue by billing.
Right.
Well, this was a great talk. This was a lot of fun, Robert.
Yeah, absolutely. I think we've been having fun with this so far, and I got to try out my new system here, so I can get rid of the shaky camera.
I think the shaky camera was fine. Well, I'd like to thank you all for joining today. We had a great time doing this, and hope that you understand a little bit more about some of the differences between our current healthcare system, which is a fee-for-service healthcare system, where the incentive is to generate revenue by billing, and value-based care. If you want to learn more, especially with the full risk value-based care option, please visit us at chenmed.com/resources. There's plenty of articles and plenty of information there about value-based care, and especially the full risk value-based care model. We look forward to seeing you again next week.